This literally has an office, about a quarter mile down the road here. My nurse practitioner, Catherine's also joining us this evening, so if you can't get answers out of me, she'll definitely be able to help you if she doesn't fall asleep. It's been a long day. So I appreciate you guys being here tonight. It's a little bit late in the game. Like Kyle said, we'll try to kind of stay true to form, with regards to respecting your time. I'm sure most of you want to get out of here, go home, and get a good night's sleep. And today and tonight especially, we're going to be talking about what's called having the healthiest heart around, right? Really difficult question to answer. But I'll see what I can do to kind of help you in that regard. With regards to disclosures, usually when we're giving talks, as physicians, we have to give kind of financial disclosures. Do we have any ties to anything that we're going to be discussing so there isn't any inherent bias? My disclosures for this evening are none of those. I just wanted to tell people that I absolutely love what I do. I will tell you that I hate drugs, but I am not anti-drug. Okay, and that's a very important concept, and we'll kind of talk a little bit about that. I'm very pro-knowledge in the sense that, at our institution, we love to stay educated. We like to stay informed and very contemporary with respect to what we're doing in medicine. We think that's important, mainly because my goal tonight, I'm not here to tell you what to do. My goal is to provide information and knowledge, which is kind of what we do on a day-to-day basis, and help people make informed decisions with that information. And at the end of this talk, after I went through it a couple of times, I realized you're probably going to be more confused after this presentation than you will be solidified in your knowledge. So the reason why we're here tonight, when we're talking about healthy hearts, the heart is a very complex organ. It's a muscle. It has an electrical system. It has a plumbing system, really, whereas I kind of make my living, so to speak, and where we're able to help most patients out. And that's because atherosclerotic disease, which we're going to spend some time speaking about, is the most common form of cardiovascular disease that results in more deaths around the world with respect to heart attacks that lead to congestive heart failure and things of that nature. So the center of our universe is basically the artery, and in particular the arterial wall and what happens inside of that wall. Okay, so that conduit that you're looking at kind of down the barrel of the gun, theoretically, and this is kind of an old way of thinking, we have what's called a healthy artery, right? Because we assume people have healthy arteries, right? When you're born and you're young, we make the assumption that when you're in your teenage years, when you're in your 20s, you're not affected by anything, so thereby you have healthy arteries. But what I'm going to show you in reality, that may not be the case. But the way we were taught in medical school essentially was that you begin to develop early in the course of life these atherosclerotic streaks, these fatty streaks, where cholesterol predominantly deposits secondary to a certain degree of inflammation that's occurring inside of the body in the lining of the blood vessel wall. So the wall of this arterial muscle, so to speak, okay, has three specific linings. Underneath one of them is where the predominance of the atherosclerotic process, or this atheroma, which is usually a combination of lipids and inflammatory cells, deposits itself under. And it's a progressive disease process. It's not something that sits there. As you get older, it gets older with you. Depending on what you do in your life, some of the potential medical conditions that you may or may not have will stimulate this process to accelerate at even a greater pace. So it's an important concept to understand. And the thing that we're ultimately trying to prevent is that plaque that's almost ubiquitous in all of us at some point throughout the course of our lives. We're trying to prevent the end game, which is rupture. Okay, so plaques have a tendency to rupture. This is how people experience heart attacks, strokes, and other potential complications of cardiovascular disease. Now, it's important to understand that cholesterol and the concepts of atherosclerosis have always been given kind of this label as it's a disease of westernized society, right? We've heard that a million times. It's because we're really bad people, we do really bad things to ourselves. Therefore, because we eat so well in this country and all of the wrong things more often than not, what we consume ultimately leads to this atherosclerotic disease process. Well, there is certain truth to that, but then there's more to the story. Interestingly enough, we also do a really good job of exporting it, right? So back in the 1990s, when the Soviet Union became Russia, the first corporation that landed itself, okay, in the square in Moscow was McDonald's. Okay, so we really do a good job of not only westernizing ourselves, but westernizing the rest of the world, which does result in higher rates of atherosclerotic disease. Now, interestingly enough, if you look back, okay, centuries ago, and how do we know that people were suffering from the same exact disease process that I was just showing you, telling you that the way we've been trained to think that this is a modern medical condition? We know that when we study Egyptian mummies, okay, so these are mummified bodies, they entombed 54 of these Egyptian mummies, and they did CAT scans on them. Okay, so within the tomb, they actually CAT scanned mummified dead bodies, essentially corpses, to look and see what was inside, right? They didn't want to disturb the actual tomb itself, but basically using this very advanced technology, we were actually able to see inside. So you get past the beautiful gold of the tomb, and you can see inside of the body where that arrow is pointing, you see the heart, but where all of that white shadowing is, that is calcification inside the coronary artery of probably a 19 or 20-year-old prince and or princess that was buried in this tomb. Okay, this is basically in the Ptolemaic period. This is around 350 BC. Okay, they didn't have McDonald's. Okay, so can the story be all about poor nutrition? It's highly unlikely that it is, because we know that this disease has existed for centuries. They had access to beef and fowl and other things, so they were consuming meat products and things like that, but they didn't have processed foods, right? They didn't have fast food and so forth. There wasn't an abundance of sugar. They weren't chewing tobacco. It wasn't available at that time. You can make an argument that perhaps exposure to some other toxins, obviously they're burning wood to keep warm and things of that nature. So there's a lot of there, but this has almost invariably very little to do likely with circulating levels of cholesterol, right? Because we've all been taught and trained that high cholesterol leads to cardiovascular disease. Well, there is some truth to that, right? It's definitely an additive component, but is it the whole story? So I'm going to present the case of an individual that I actually saw 48 hours ago, because I think these things are relevant. Likelihood of something really bad happening to this person from a heart attack, stroke, dying, etc. His risk was 22%. So it's not an insignificant number. That's pretty much 1 out of every 5 patients is going to be dead from something cardiovascular with this presentation at his age, okay, from a cardiovascular event, heart attack, stroke, death, etc. Now, the interesting thing is, what's the average life expectancy for a man in the United States of America? Anybody?
Probably beyond 75.
77. And it's actually going down. It's not going the other way. So 77. So he's 2 years away from the likelihood of reaching the average, right? So he's in a pretty decent age category. His total cholesterol was a little bit elevated. His HDL cholesterol in a pretty decent range. His lousy, or that's the way we've been trained, right? LDL, lousy cholesterol. HDL, healthy cholesterol. Guess what? There's a little bit more to that story as well. But those were his numbers. He got referred to us because his primary care physician obtained an EKG, which is very commonly performed. Did an EKG, found the quote-unquote abnormality. There was a suggestion that maybe he had a heart attack in his previous life. So he came to us for further evaluation. He wasn't having any symptoms at all. He's never had any chest pain, no shortness of breath. He wasn't lightheaded, no palpitations. The guy was feeling perfectly fine. Okay, all he was taking was red rice yeast, had no other medical conditions, had never been hospitalized, etc. We went ahead and we had done an echocardiogram on him, which is essentially an ultrasound of the heart to look and see whether or not that electrical abnormality matched with something structural. We found that that was perfectly normal. Sometimes electrocardiographic things that we see don't necessarily match up, so they're there because of who you are. They don't necessarily signify that something's actually happened to you. So that kind of confirmed that. Now, he went back to his family doctor, and then a year later, his family doctor sent him for a calcium score. So very similar to what you just saw with the mummified tomb corpse. We did the same, they did the same cardiac CT. Now, interestingly enough, we never did that. So he had come to us a year prior, we never did the calcium score. Why? Because we usually don't do calcium scores on people over the age of 70. Why do you think that is? Because almost invariably, we know we're going to find something. Okay, so in reality, if we already know that it's there, if we're not going to do anything different to manage the patient, especially an asymptomatic patient, he's already treating himself, you know, with a statin-esque type substance that's naturopathic, is there a need to proceed with that? Well, we don't do it, but they did it. So they sent him back, you know, for further evaluation and discussion. All right, so these are kind of cases that we see every single day. They lend into some of the complexity of what goes on out there in the medical arena. And I think it's a good backdrop of kind of the next, you know, few minutes of this presentation. So what does coronary artery calcium look like? You just saw that with the mummified body. These are more conventional images. What you see in the middle of the screen, we're looking down. You can see that pipe coming out of the aorta, which is the big structure that comes out of the heart. And what you see, you can't really see there. That's not going to hit up there. But the white pieces, those tiny little white pieces, that's the calcified plaque. And when we quantify this, that's what calcium scores do. This is not looking at blood flow. This is not looking at what's going on in the artery with respect to a blockage. All a calcium score is telling you is whether or not you have calcified plaque, meaning coronary disease inside the arteries of your heart. So the presence of is abnormal. The absence of is, for all intents and purposes, normal. When when you look at what this looks like when we get inside the body, so this is a patient that we took a picture of invasively. So when we do heart catheterizations and things like that, we go in there, we inject dye. The dye fills up the artery. We look at it under X-ray. The arrow is pointing to where the most significant stenosis or narrowing within the blood vessel is. We also have the ability to perform what's called intravascular ultrasound. We can pass a little catheter down there and then look at it, again, down the barrel of the gun, and you can see over there, the green representation, the big circle there, that's the atheromatous plaque. The little blue circle is the lumen, or where the blood is flowing. And amazingly enough, despite the way it looks angiographically, the lumen itself is still, for the most part, preserved. This is an adaptive mechanism of blood vessels inside of your body. Hey, Vijay, how are you? So this is an adaptive mechanism. It's called positive remodeling. So as plaque begins to form inside of an artery that's normally circular, it then becomes an ellipse to accommodate the plaque. Now that's to a finite point. Eventually it can't accommodate, so then it will begin to encroach on the actual lumen, that small black area itself. This is what it looks like if you have a bad blockage in the artery of your neck. So this is a carotid artery in a patient that we had done an angiogram on, taking a picture, and you can see it's really difficult not to see what's normal and what's abnormal. If you're not sure, that very tight, narrow segment where the blood is flowing through, that's right here in the carotid artery, and that's ultimately what leads to 1/4 of strokes. So it's a very important process for atherosclerosis. Now this is what it looks like when you take it out of the body. Okay, so when I send the patient to a vascular surgeon, this was a patient done right over here at Hunter Medical Center that had a very substantial blockage here in the artery of the femoral artery. Okay, and it was so heavily calcified, so badly blocked, there wasn't anything that we could do with a balloon or a stent. This needed to be removed. But if you ever wanted to see what plaque looks like, sorry to ruin your evening if you haven't had dinner yet, but that's what it looks like. It's pretty nasty stuff. Now this happens over decades. This is not something that you're going to see in a 16-year-old. This is something you'll see in more advanced stages in life. If it's younger, it's usually because they're a smoker and a diabetic and so forth. So what are we trying to prevent? Ultimately, at the end of the day, what we're trying to prevent, like I said, is heart attacks, strokes, dying prematurely. And what I'm showing you here is what platelets look like. So platelets are little blood cells, right, that are produced by the bone marrow in response to injury and the response to inflammation. These platelets are really what's responsible for causing arteries to heal. But in essence, we heal so well sometimes. So that little blockage that I showed you, if that plaque ruptures, you can see where the angiogram, the dye just stops halfway down. There's no more blood vessel. Why? Because those platelets, essentially, when they get activated, and you can see on the bottom part of the platelet representation, that's what an activated angry platelet looks like. It's now active, it's adhering to one another, it sends out other signals to draw more inflammation because it's trying to heal the rupture at the site of the injury. The body does such an amazing job at healing that wound, it closes the blood vessel down, and this is why people have heart attacks. So it's not an intentional thing done by the body to hurt you, it's trying to heal you, but in essence causes the heart attack. Okay, so cholesterol. So what does it really all mean? I actually love this one. It's one of our patients gave this to us. I can't remember who it was, but I just loved it. It just got laid. And I'm a big egg fan, you know, and we'll talk about that. I'm going to leave most of the dietary stuff to Kyle because that's mainly his expertise, you know, within this arena. But, you know, I love eggs. I eat eggs all the time, you know, and if you have any questions about that, we can talk about that. Hopefully we address it a little bit. But cholesterol is really important to understand what it is. You know, cholesterol is this kind of waxy substance that kind of floats through this aqueous environment inside the body, right? The bloodstream is an aqueous environment. We're mostly made or comprised of water with other elements, you know, obviously that are produced from a biochemical perspective. But fat, just like oil, it really doesn't dissolve well in water. So when you have circulating cholesterol in your bloodstream, something needs to transport it. Okay, something needs to move it from point A to point B, whether it's into the bile and into the liver where it gets exterminated, whether it ends up in your blood vessel where it forms a plaque. Okay, we have proteins, they're called lipoproteins. And I want to spend a little bit of time on this because this is really important. We have HDL, we have LDL, right? We have chylomicrons, we have triglycerides. All these lipoprotein particles are responsible for are that movement, okay? They are the transport molecule that picks up that cholesterol and decides where that's going to end up, okay? We call LDL the lousy one, HDL the good one, but again, those terms are not necessarily true because LDL and HDL and all of these other lipoproteins have very substantive biologic, positive, and beneficial functions inside of the body, okay? So we have to ask ourselves, is LDL really lousy, or have we just made it lousy for a multitude of different reasons? So when we look at millions of years of evolutionary, okay, evolution and engineering, these are the particles on the left, just to give you an idea of what the quote-unquote lousy cholesterol does and the healthy cholesterol does and the very low density lipoprotein does. They do a lot of really, really good things. They are responsible for our immunity. They are responsible, again, for bile and cholesterol elimination. When cells get injured for whatever reason, whether it's smoking cigarettes, whether it's a motor vehicle accident, no matter what it is, these lipoproteins are responsible for everything from cell repair. They do immune surveillance, meaning they're literally floating around the bloodstream looking for invaders inside of the body. Okay, so very relevant in the time of COVID. They modulate inflammation. They also surveillance for cancer, right? They're always on the hunt looking for something that's not supposed to be there. Very, very important mechanisms. So again, this evolutionary engineering looking at LDL, what else does LDL do? Again, remember, this is supposed to be a lousy lipoprotein, right? This is what we've been taught forever. But, oh, by the way, it's responsible for receptor processing, right, and caveoli, and I'll show you what a picture of that looks like. So what happens is basically you get cavitation into a cell where receptors sit, and they take things out of the bloodstream, like cholesterol, like insulin and glucose and things of that nature. So these things become really, really important. They're also the basis, as we know, again, chole means bile and sterol, right? Fundamental principles of kind of biochemistry. So these are the fundamental building blocks of, guess what? Really important things called hormones, right? So testosterone, estrogen, estradiol, right? These are things that we cannot live without, right? People supplement themselves with these things when they don't have enough of it. So LDL is responsible for that. And they also carry what are called fat-soluble vitamins that are responsible for scavenging and ravaging all the really nasty kind of what are called free scavengers, things that are toxins or endotoxins to the body. And they're basically antioxidants. Okay, so just like we talk about that all the time with our diet and nutrition, how do we achieve that? Well, we've already got the machinery for it. Okay, we already have it. Okay, so then the question comes, right, because this talks a little bit about cholesterol, it's about statins and why we use them and things of that nature. Look at all the amazing things that these lipoprotein particles do, and we have to ask ourselves, should we tamper with millions of years of evolution from a bioengineering standpoint that our bodies have done everything? They have all the things, all the tools necessary to fight infection, to fight off cancer, to fight cardiovascular disease, everything that you basically encounter from a medical perspective throughout the course of your life, we have the engineering to deal with that. But the question is, well, how do we augment that? Okay, how do we not offset that? And that's the more challenging question. Now, interestingly enough, I think this is a really important point that if LDL, okay, the lousy, quote unquote, lousy cholesterol, was responsible for all of this horrible stuff, even though I've shown you just the opposite, what happens if we remove it all, right? So there's actually a genetic condition called A-beta lipoproteinemia. All that basically means is that you are born without those lipoprotein transport molecules that not only transport things, but have all these other biologic functions. What happens if you're born without it? Well, you think these people would live how long? If LDL is the harbinger of all bad things and you get rid of it because genetically you are destined not to make any of it, you're going to live forever, right? But that's if that was true. The reality is what happens to these people. When you look at these people, the reality is they undergo a multitude of things. So all the things that I told you that were good in the previous slide, they don't have the ability to generate these things. So they fail to thrive, they get recurrent infections, they end up getting blindness, all sorts of neuromuscular conditions and problems, and guess what? They die in their third or fourth decade of life. They never make it, okay? Because they don't have the ability to produce all these kind of life-saving, day-to-day operational lipoproteins that are responsible for all the amazing things that the body's capable of doing. So the pathway in and of itself, okay, not to bore you to death, if you look at it, and when we talk about statins, when you talk about drugs that were specifically designed to inhibit the ability of the body to produce cholesterol, what you see is that the occurrence of the pathway happens so high up in the production phase that inhibits all the abilities of the aforementioned things that are in pink. So whether it be the lower production of peroxidases, whether we talk about coenzyme Q10 that gets depleted, right, which is responsible, that's kind of the spark plug in the machinery inside of muscles that causes muscles to contract because you have adenosine triphosphate and other active energy sources that are occurring. These little rafts and these caveoli that I was talking about before where these receptors sit and they live in that lipid-rich environment. And also processing of insulin receptors. Why is an insulin receptor important? Because if you don't have insulin receptors, you can't remove what from the bloodstream? You can't take glucose, right? So glucose now is escalated in the bloodstream, so you have problems. And probably the most important thing and relevant to this talk is it actually inhibits the ability of the body and vitamin K to go from what's called K1 to K2. These are basically just proteins. And what that does, it actually increases the likelihood of vascular calcification. So the body has this wonderful mechanism to prevent calcium from forming in your arteries that I just showed you. And part of that process is through this cholesterol synthesis process. So when you inhibit it, ironically enough, what do you think statins have been actually shown to do? Statins have been definitively shown, without a doubt, to cause what? Higher levels of vascular and arterial wall calcification. It's a known, documented fact. Now, two sides to the story. There's one side of the cardiology community that says, aha, well, this is the mechanism of why these drugs work. They stabilize plaque, right? Because if you have calcium in that very soft, lipid-rich environment with a lot of inflammatory cells, if you stabilize that with calcium, okay, then that plaque is less likely to rupture. Now, we don't necessarily have proof of that, but that's the argument for some people who have always been looking for the mechanism of why statins do a good job at potentially reducing cardiovascular disease. And then there's the other of us that are saying, wow, here's a drug that we're using to do one thing, in essence, is preventing the body's innate ability to prevent vascular calcification from forming, and now this drug is directly associated with that. So is that really a good thing, or is that a bad thing? I don't know. Again, providing you with the knowledge, these are things that we struggle with on a day-to-day basis. This is just showing you that mechanism of action, where you have this kind of cavitation within the cell. The green thing is the receptor, and this is in a cholesterol-repleted environment where there's plenty of cholesterol available. And then in a cholesterol-depleted environment, you can see that the receptor becomes very, very inefficient. It's not living in that very nice space, and I'll show you what that ends up translating into. So a long time ago, they did a study. They looked at the statin use. So if you put somebody on a statin for high cholesterol, and what was the risk of developing diabetes? Now, this was purely a women's initiative study. So they literally looked at women, over 150,000 of them, and they looked at half of them that were on statins and the other half were not. And what they found was that the ones that were taking statins had about almost a 10% risk of developing diabetes over the course of their therapy, and the ones that weren't, it was about 6.4%. So you're talking about almost a 3 to 4% difference, meaning that the people taking statins had a much higher incidence of developing diabetes mellitus. Now, the ones that are favorable for statins, meaning the people that are advocates for it, suggest that, well, these are people that were destined to become diabetics to begin with. Okay, so they take kind of a very negative view of the world. They take a very negative view of people and saying, you know what, you guys are overweight, you're not taking care of yourselves. And there may be some there, right? Because we definitely struggle with that. But that really wasn't all of the patients in this clinical trial. So it's not simply patients that were predestined to develop diabetes. I would argue once you develop diabetes, you are really behind the 8 ball. And we need to do every single thing that we possibly can to prevent that from happening. Okay, so we take the opposite stance, which is, wow, we have to be really cautious. And for those of you, and we have some patients here in the practice, we talk about this all the time. We have to weigh that benefit and the risk of somebody developing diabetes when they already have cardiovascular disease, they've already had a heart attack. We give them a medication potentially where there might be a marginal benefit for them. It's definitely going to lower their cholesterol. But in reality, if we replace one disease process with another, have we done the patient a service? That's a question that we all have to answer, right? It's not necessarily for one person to decide. This was also a very elegant component of this where they looked at CoQ10. So coenzyme Q10, which we know those levels are depleted when patients take these medications, okay, they actually only took, now granted, I'll tell you, it was only 10 patients pretty much in each arm, but it was a very elegant study in the sense that they measured a lot of muscle function enzyme activity, and even more importantly, they took biopsies of people's muscles. So people were either on statin or they weren't on statins. They looked at functional enzymes that occur inside of muscle activity, and they also took biopsy to see if there was any injury going on. And interestingly enough, for the ones that were taking statins, what they found was that their blood pressures were higher, their sugar levels were higher, their coenzyme Q10 levels were depleted. Again, this is kind of the mechanism of how muscles ultimately function. Other oxidative enzymes that are responsible for, again, free scavengers and producing a low inflammatory environment were reduced. Levels of ATP, so this is what you get out of the biopsy. You take the biopsy, you can actually measure how much adenosine triphosphate is actually in those muscles, right? That's the thing that causes muscles to contract. There were depleted levels of that. And oh, by the way, guess what? There was a higher level of insulin resistance. Why? Because we know that these drugs potentially impact these receptors. Okay, so it's really painting a picture of, again, me not saying that these drugs are terrible. There's definitely some benefit, but there's a lot more to the story than simply saying every person with high cholesterol has to be on one of these medications, because that is not factually true. We need to take the patient into the entirety with regards to when we make these decisions. Now, 2 pieces of clinical data that I'm going to share. This is probably not going to bore you to death, but when your doctor, your nurse practitioner, anyone taking care of you decides to put you on a medication, ultimately, the goal should be one of 2 things. It's not always one of 2 things, but almost invariably should. It should be done to either improve your quality of life, okay, so you're having symptoms, we can make those better, or we make you live longer. Okay, if you're getting a drug, okay, and someone gives it to you, you have to ask, is this going to improve my quality of life? Is this going to make me live longer? If it's not doing one of those two things, you really need to understand why they're giving you the drug. Okay, it's very, very important. And it's not to say that there aren't drugs out there that, of course, people have no symptoms and they're still going to make them, potentially live longer. But these are conversations that you need to begin to have. When you look at the most compelling data for statins, the original trial that was done back in the 1980s, and ironically enough, was never published in any peer-reviewed journal because that's not what we did back then. Pharmaceutical companies used to do trials. They would do 10 of them. 9 of them they didn't like, they would throw them out the door. The one that they liked, that's the one that they would tell you. And they would tell you, this is the study, look at what my drug has done, okay? And now I need to convert all of you to taking that medication. Well, that's a little suspect because, again, talking to about this particular study, which looked at simvastatin, one of the older, kind of lesser intensity statins, we don't use it necessarily a lot anymore. When you look at the trial, simvastatin, over the course of 5.4 years, reduced the likelihood of death, this is lowering patients' cholesterol with a statin, reduced the date of death by 0.6% per year. Okay, now if you multiply that by 5, it gets a little bit bigger. But again, 0.6% per year, okay, each year. Okay, so that was the absolute reduction in mortality. So then again, you have to ask yourself, is this drug worth taking it for a less than 1% reduction in mortality? Now, I will tell you a 1% reduction in mortality can be a really big deal. Okay, and we do make changes clinically, based on medications that we give for a 1% absolute reduction. Okay, because you can imagine if you have millions of patients, 1% is not an insignificant number. So you have to take that into context. But this is a very, very weak study, generally speaking. Now, what they report to you is something called relative risk. So when you look and they mark it, all you have to do is watch the next commercial that you see for a drug, and they will talk about not absolute risk reduction, they will talk about relative risk reduction. Why? Because it's a huge number. Okay, there are differences in the way we calculate. You want to know what the absolute reduction is. Now, Lipitor, interestingly enough, or atorvastatin, and some of you are probably taking this medication, in a primary prevention setting, when we look and analyze scientific papers and we read them, okay, there's something called a number needed to treat. It's an NNT, meaning that how many patients in that study do you have to treat to prevent one event? Okay, there's also something called number needed to harm, which is how many patients do you need to treat to have one really bad thing happen to the patient from a side effect perspective. Okay, so it gets a little bit complicated, but when you look at this, the absolute difference, for these patients in a primary prevention setting, you actually had to treat 104 patients for 5 years. Okay, the number needed to treat was 104 for 5 years to reduce one cardiovascular event, and not even necessarily the death kind. Could have been a non-STEMI or a small heart attack, etc. So you have to keep that in the back of your minds that these things tend to be overblown. Okay? Now, if you take something like the Mediterranean diet, okay, which causes absolutely no harm, actually tastes pretty good, it's a pretty decent way of living your life, okay, the number needed to treat is actually 1 out of 54. Okay, so if I give you an option, you can go on this medication because you have high cholesterol, okay, and I need to treat 104 patients, and you may be the lucky one, okay, that ends up having a reduction in event 5 years later, versus I tell you, follow this diet strictly, okay, live your life like this, and there's actually a 1 in 54 chance that you're going to have a benefit. You have to ask yourself, this one comes with an economic price, comes with potential side effects, this one comes with none, okay, and it actually does a better job. So these are the things, again, that you need to begin to think about as you make decisions. Now, last thing I'm going to focus on is inflammation. So when I said there's more to the story and trying to explain away why a 19-year-old mummy, okay, would have horrible calcification in their artery, okay, not based on the fact that they were circulating levels of cholesterol for 20 or 30 years that were elevated, okay, there's a story called inflammation, which is something that you really need to begin to understand because this is where the there is. So this process on the left is an aorta. It shows you the atheroma that develops, okay, we already have discussed that a little bit. Ironically enough, the inflammation that occurs inside of that plaque is identical to the inflammation, okay, with regards to a cellular mechanism that occurs in people who have things like rheumatoid arthritis, systemic lupus, any disease, even if it's cancer. Most things are caused by underlying inflammatory disease processes. Now, this is actually a very interesting study. I'm going to first show you the one that they did in mice. Some people who like little mice, I don't want to upset you, but this is what we do when we look at these things. And then I'm going to show you the one in humans because they are side by side, essentially the same. So what you're seeing on the bottom, you see a little bit of uptake of the red. That's what's called fluorodeoxyglucose. It's basically just a substance that we use to try to identify where the inflammation is occurring in someone's body. The picture on the left is your aorta. Okay, the picture in the middle is your spine, and the picture on the left is your spleen. Okay, so you can already see that this mouse, okay, that was exposed to very high levels of circulating cholesterol because they fed it that, okay, had baseline low levels of inflammation to begin with. Okay, then what they did was they took the poor little mouse and they tied off the artery, okay, one of the arteries to the heart, and they caused the mouse to have a heart attack. While they did that, they did the same thing and they repeated it, okay, to see how much the uptake was of the FDG, and you can see tremendous degrees of inflammation. All right, so tremendous degrees of inflammation. Very, very important concept. Why? Because there's an ongoing project right now that's called PESA. It's a multinational project started in Spain. And what they did was they said, we have all this amazing imaging now. We have MRI, we've got PET scans, we've got all this great stuff. Let's put it to use. Let's take a group of 40 to 54-year-old young, healthy men who have absolutely no medical problem, don't smoke cigarettes, anything. It's kind of the healthiest population theoretically that we have. And let's start to image them. What they found, surprisingly enough, was in all of these young men, not only did they all have plaque, but a predominance of them had inflammation. Okay? And a lot of them had inflammation with no evidence of plaque. Okay? So the story here is that, generally speaking, the precursor to atherosclerosis is inflammation, which is something you cannot see with the naked eye or even any rudimentary testing. You would have to go for some sophisticated testing to identify whether or not you have inflammation. Why? Because that inflammation ultimately is what damages the lining of the blood vessel wall, which ultimately sets up the nidus for all that deposition of all that plaque to go inside of the body, and then eventually it progresses over the course of time. Okay, so what's happening to us right now is ultimately what does us in later. Okay, everyone sitting here most likely has either inflammation or plaque in their body. It's just a fact, okay? And the only reason that's not true is because you haven't looked. You know, it's an unfortunate circumstance, but this is the reality of what we're walking around with. These are 40-year-old, otherwise healthy men who had no idea anything was going on with them, yet their body is completely inflamed, whether it's environmental exposures, whether it's nutritional exposures, whatever it may be. Okay, so very important concept to understand. Now, one of the tests that your doctors should be routinely sending for the most part, depending on your age and some other risk factors, would be something called a CRP. CRP is a systemic, non-specific marker of inflammation. Okay, and it was actually identified in the 1930s. And inflammation is one of these things that's kind of been poo-pooed by doctors for a very long time because we were so focused on the lousy cholesterol concept. Okay, but now we're starting to understand that there's more there. And this was done back in 1997. Ritker, who's kind of like the international expert on CRP, basically designed the blood test for it, basically looked at people who had different quartiles of CRP elevation. So if you had levels of inflammation and to what degree. So the gray bars are basically higher degrees of inflammation as you go across the screen, and they looked at, in the white bars, people who had these degrees of inflammation but were taking a little baby aspirin a day. And you can see, simply by taking an anti-inflammatory like aspirin, you can see the CRP levels maintain themselves over the course of time. And more importantly, when you look at the right side of the screen, you see that those C-reactive protein levels, so the higher degree of inflammation, the higher the likelihood over the course of time that you're going to likely have a heart attack. Okay? So we know that inflammation is directly correlated to that. And then we look at other traditional risk factors. Right? We talk about high cholesterol, we talk about diabetes, we talk about exposure to smoking. When you look at high sensitivity C-reactive protein, this systemic inflammatory marker, you can see it's furthest to the right, basically meaning that it is an independent risk factor, more powerful than any of those other risk factors. So if you walk into your doctor's office and your CRP level is 4, you've got a problem. You may not know it yet, but something in your body is going on, is causing systemic inflammation. Again, this is not isolated to one vascular territory. Just like I showed you with the spine, the spleen, the aorta, it's everywhere. It's everywhere. So you need to be very, very concerned. Now, we don't necessarily have any specific treatments directed towards that, but recently there's been a lot of movement in that direction. There was a study that came out a couple of years ago called CANTOS. It was basically looking at a drug specifically to reduce levels of circulating what's called interleukin-6. So you have a number of interleukins in your body. They're just inflammatory things. They're called cytokines, things that cause fever, they're pyrogens, etc. So what they did was they basically gave a group of people that were already being treated maximally with medical therapy for their heart condition. All the patients in the study had already had a heart attack, so they were already on good drugs. And what they said they're going to do, we're going to give this drug and we're going to reduce these levels of circulating inflammatory markers inside of the body and make a determination of whether or not this results in a clinical benefit for the patient. And what they found was there was, as you can imagine, no effect on cholesterol. Okay, so this anti-inflammatory drug, very aspirin-esque, but taking it to a higher level, didn't have any effect on cholesterol. Good, it's not supposed to. But what it did do, the higher the dose you went, the lower levels of interleukin that you found. Now, what did that translate into? That translated into a reduction in cardiovascular events. Okay, so when you began to lower degrees of systemic inflammation, we started to see signals that the people who had lower scores of interleukin-6 were actually doing better with regards to having a recurrent heart attack, stroke, or any new cardiovascular event. Now, why is this drug, you might say, not available? Okay, because the study was published about 2 years ago. I think when I gave the Hillsborough talk, we talked about this. Because they went back and they continued. Novartis, who is the company that actually produced this medication, what they found looking back was not only did it have a beneficial effect for patients with cardiovascular disease, but they found this very dramatic signal that when you looked at cancer mortality and the development of cancer, it was dramatically beneficial. Okay, so they're looking at it now as a potential chemotherapeutic agent to use in the cancer arena. So this is how these things work. So right now, it's not commercially available because they're going back and analyzing all the data and seeing, again, is there a there there? Now, we don't know, okay, but there's very strong signal, but it's not available. So last couple of slides. So what do we do about this? Can we reverse it? Can we stop this process from occurring? Well, looking at the above slide, you see what's called a nuclear perfusion scan. So that's the two sequences on the left-hand side. When you do a nuclear stress test, I'm sure someone in the audience at some point's had a nuclear stress test, this is what they're looking at. And what the arrow is what's called before treatment. So what a nuclear perfusion stress test looks like is when you go and exercise at full capacity, they image the heart. They inject you with radiation isotope. It gets taken up by the heart. Okay, the cells basically are metabolizing it. So then you pick it up on the nuclear camera. And what you can see, you should see a nice round donut. Everything should look the same. The perfusion should be the same if everything is normal. If you have a blockage somewhere, then you get a little bite out of the artery. Okay, so you're not seeing the artery, you're seeing the muscle that's fed by that artery. And you can see the defect. When you look at the corresponding image, so this patient in this trial had an angiogram done. So with that top left picture, match it with the first picture on the angiogram, you see that very severe, tight narrowing inside the blood vessel. Okay, now you go to the bottom image and you see the donut. This is the same patient 32 months later. And what you see is now the nuclear perfusion scan is almost essentially normal, okay? And you look at the angiogram, same exact patient, 32 months later, it looks normal. So what happened? This individual is in a study where they basically went on a plant-based diet, okay, for 32 months, okay, and nothing else. No medical therapy, no treatment, no statins, no lowering anything. They basically put themselves on an exercise and a nutritional program. This happened to be a plant-based diet program, and this was the corresponding result. So anybody who tells you that you cannot reverse heart disease to a certain extent, it's not true. We've seen it. We've seen it all the time. Okay, so this is a very important concept to understand. Now, the problem is the there is you have to actually be able to do it, right? So when I say I hate drugs, but I'm not anti-drug, why? Because guess what? We have patients that walk into the office all the time. Some of them are really, really good. They've done all the appropriate things, and they've made big changes to their life. And then there's the rest of us, right? That we don't necessarily do a great job of doing what we're supposed to do. And when that happens, unfortunately, guess what? There is no alternative. Because if you're not using the things that Kyle and Mike are going to be talking about in a few minutes with regards to exercise and nutrition and these things that are the two greatest drugs in the history of the world, guess what? You're destined for something not so good. Okay? So it's really, really important to understand that. So nobody wants to take drugs, but does everybody really want to do what they have to do, right, to make the appropriate changes in their life to do what I just showed you? That's really hard to do. Some people have done it, right? And they make an attempt and all of a sudden their life changes. They lose weight. They're not on blood pressure medications anymore. I mean, it's an incredible thing. I mean, we see it all the time. So it's kind of inspirational for us, but it's hard to do. I would say it's the minority of patients. The majority, unfortunately, do succumb to, you know, these things that we don't necessarily want to be engaging in. So that's not what we're engaging in. This is kind of what my house looks like when I'm doing well, okay? When I'm eating well, right? And I have time to cook and shop for food, okay? This is what my dinner looks like. These are pictures from, you know, my thing. I get excited. I'm like, wow, I'm doing a great thing. I'm going to take a picture of it. Okay, but there are times where that donut is sitting right there too. All right, we all struggle. These are the challenges, right? It's more mental than it is physical. But this is what it should look like. Okay, and I'll leave you with this, you know, because this is going to lead into, obviously, Kyle and Mike's talk. And actually, Catherine shared this with me. I love this one. But yeah, you got to exercise, you know. People, movement is life, right? You've heard that a million times. If you don't move, you will be destined to die. And the older you get, the harder it's going to get. And it's very easy because we see that all the time. You know, people who have given up and they stop moving, even if it's just activity of some variety, it's just a matter of time. But if you continue to move throughout the course of your life, and God forbid you can get a little bit of exercise in every now and then, it's all going to be beneficial. So I'll leave you with that and turn it over to Kyle and Mike to kind of move on to, you know, probably some even more important stuff and kind of emphasize this. And obviously we'll be around. So if you have any questions at the end, just let me know. Good.
All right, guys. So first thing before I get into it, so coming down the home stretch, just sit up tall, first of all. Sit up nice and tall. Take your head, try to bring your chin down to your chest. Then open it up, bring it back as far as you can. Get 10 of them. Let's get some blood flow up to the brain. This should feel pretty good. All right. After you did 10 front to back, let's go 5 on each side. Try to go to shoulder to the other shoulder. You're probably going to hear some stuff cracking and popping in there. And last one you're going to do. Get 3 big circles each way. Everybody should be feeling pretty good. So this guy up here is one of our members, Andrew Tina. He's been with us 4 years now, I think, right? 4 years. He did this, the transformation you see, in less than a year, pretty much. Following some of the advice that Mike and Andre have gone over, really taking to heart the stuff that I'm going to try to teach you in a short period of time with fasting and something called mind mapping. You heard both of the guys say, we can give you all the information, but it really comes down to, can you form a habit around it? That's the big thing. If information was the only problem, you could just Google something and be done with it. You would know how to do it. Facts are the facts. When I go through this stuff, a lot of this is probably going to seem, if you're not familiar with stuff that I teach, it's going to seem completely opposite of what you know to be true, or you think you know to be true. So mind mapping is basically, it's one of my passions, is how your brain forms habits. It's a science of how the brain forms habits. Compliance is a science. You heard the guys say that. But that means you can still have pizza, you can still have beer. We're not looking for you to be perfect. As soon as you go down that route, like if you do a New Year's resolution, it's not going to work. You've probably all tried stuff like that. We talked about how lack of information is not the problem. 6 out of 7 people can lose weight. Who in here has done a diet before? Raise your hand. Almost everybody. Has it worked?
Yes.
Kept the weight off?
Yes, I did 20
Good.
pounds.
Good for you. Very rare rate, 5% are right there. It's not very common. A lot of people can lose weight, they're going to put it right back on. They're going about it the wrong way. Your brain will not form a habit around anything it does not find pleasurable. That's very important. So you have willpower. If anything that's purely willpower based, it's not going to work. You need a little bit of willpower at the beginning, like getting a rocket ship launched. But at the end of the day, the part of your brain that uses willpower, it's burnt up. The frontal part of your brain. Okay, the executive function of your brain. So you might have all the best intentions in the world. You have a long day. A lot of you got families. End of the day, if you're trying to implement that habit, like eating better, getting to the gym, it's probably not going to work. So you got to realize that. If anything is strictly willpower, you're going about it the wrong way. Couple what I like to call fake fitness experts. There's a lot of them out there. A lot of them out there. Weight loss is simultaneous. This is the model where if you cut calories and you burn calories, you're going to lose weight. The body does not work like that. It's not how it works. It's a sequential process, not simultaneous. Salt and sodium is evil, not good for you. That is completely wrong. If you're talking about supplement stuff you're going to supplement your diet with, sodium is one of the top things that you need. Protein is king, carbs are the devil. Everybody's heard of low-carb diets, keto type stuff. Again, almost completely wrong. You saw what Andre showed with some of the scans up there. And I'm telling you this from somebody that used to be a competitive bodybuilder. I used to eat 400 grams of protein a day. So my thinking has shifted greatly over the years as I've studied this stuff. Sleep is overrated. We live in a society where we're fed the message that you just got to keep grinding, got to keep pushing. Sleep, you don't need it. And I used to think this too. So I'm going to show you some slides on what happens when you're not sleeping enough. That should scare you. Cholesterol is poison. Andre already showed you that that is not true. And I've had a lot of talks with Andre about a lot of the stuff we're going to present to you. Fasting. Everybody fasts. That's why it's called breakfast when you eat. You're breaking your fast. But a lot of people are taught that fasting is bad for you. You're going to go into starvation mode. You're going to lose muscle and all this type of stuff. So I'm going to cover all this stuff within these slides. I already talked about empty your cup. Empty your cup so you can put some new information in tonight. The benefits as we go through this: simplicity and clarity, sustainability. Something I like to say, it's actually a Tony Robbins quote, is complexity is the enemy of execution. It's got to be simple. With my map, you always have to ask yourself, is the approach you're taking making things more simple or more complex? If it's more complex, you're going down the wrong path. It should be making things more simple. So a little bit of brief history. Where do I start? So these top two pictures up here, I was a phys ed teacher for about 8 years. At the same time I was a phys ed teacher, I was building the business. So I trained people in the morning. I would go teach all day, go right back to the gym, get home 9 or 9:30 every night. Right? But I loved that. The hardest decision I ever had to make in my life was when I had to resign from teaching. I didn't have to, but it was a decision my wife and I made because I loved doing that. And it kind of formed a lot of the foundation for how I coach, because I realized that if I can explain stuff to first graders and second graders, concepts that we still teach your population, that I knew that it would kind of stick with people, right? People need to understand why they're doing what they're doing. The guy up in the middle in the blue shirt was the first coach I ever hired, besides a sports coach, to coach me. He's up in Canada, brilliant mind, but he kind of laid the foundation for a lot of what I believe about training, a lot of the stuff Mike went over, so very influential in my life. That's one of the pictures when I competed. That was 2007. And the guy up here, another one of my mentors, that's Jay Butler, JB we call him. He's the strength coach at Rutgers. I interned with them right when I came out of college. And he's now back at Rutgers. He came back with Coach Shiana. So he pops in the gyms all the time. Real cool guy. At the time, when I interned for Jay, he was about 34 years old. I was 20 or 21. So we're both really young. I mean, I'm 40 now, so it puts it in perspective. Inflammation. So Andre talked about this a little bit. When I go through this, I'm going to talk about insulin resistance as well. To me, they're if not medically the same thing, but they're the same thing. Insulin resistance and inflammation, right? They're hand in hand. You can't, if one is present, I can guarantee you the other one's present. The things that affect inflammation: sleep, stress, your diet, which is going to include stuff like refined sugar, and higher acidity within your body. So a lot of people, when we're talking about something I really started studying this year, is more like the lymph system. So we have the blood system, right? Everybody knows what's in the blood. as far as what we're measuring through blood work and all that. But you have the lymphatic system as well, which is just as important, if not more important. I mean, you can't have life without either one of them. When we're talking about what's going on in your body, if you're too acidic, you can be too inflamed. And one of the things you'll see that leads to higher acidity is sugar and animal protein. Cholesterol myths. So Andre talked a lot about this, so I'm not going to beat it to death, but where it came from. Ansel Keys did something called the Framingham studies. And what they did in these studies is they gave rabbits cholesterol. Now, there's a couple problems with that study. Rabbits don't consume cholesterol. They're herbivores. And with the cholesterol that they were using in the studies, and I believe this was done intentionally, it came in something that looked like a toothpaste bottle. They would leave the top off of that. What happens, the cholesterol oxidized. So they're giving oxidized cholesterol to an animal that can't really process cholesterol as it is. And they noticed it increased heart disease, all this type of stuff. And that's where a lot of this stuff, as far as medication and whatnot, was founded on. So the study is flawed from the get-go. Andre talked about this as well. There's optimal range for everything in your body, including cholesterol. It's a precursor to all sex hormone production in your body. So if you had a smoker, and Andre can answer questions at the end about this stuff, but you had a smoker, let's say with the bad cholesterol, LDL. Okay? So you had a smoker that has low LDL, and you have somebody that follows all the health and fitness stuff, they're sleeping, stress is low, that has higher LDL. The smoker is going to be more at risk of heart disease because you're adding inflammation to the cholesterol. Right? So if inflammation, Andre talked about C-reactive protein, CRP, a lot of the clients, sometimes they'll say, because I like studying this stuff, say, look at the blood work. If CRP is not on there and you're looking at cholesterol, you're not getting the whole picture. It's how much inflammation is in the body. Stress hormones, so that's a beer belly right there. That's called visceral fat. What's inside, what's making the belly look like that. Visceral fat is the fat that surrounds your organs. Your body will lay that fat down to protect itself. Now, what's it protecting you from? Everything your body does, your brain does, is about survival. So if you have a lot of psychological stress, that's mostly where our stress comes from nowadays. It's up here. Your body is going to respond physically to that. It will increase certain hormones like cortisol, which is not bad, just like cholesterol, but when it's chronically elevated, it becomes a problem. And these hormones are going to signal your body, hey, I'm under attack, but your body's processing it as a physical attack. So what it does, it's going to pack fat around all those organs to protect them from this physical threat that it thinks is coming to it. It's not a physical threat. It doesn't matter. Your body doesn't care. So visceral fat is very dangerous. Okay, it's going to surround all the main organs. Sleep is the king. If we talk about something called the autonomic nervous system, you have two parts of that. You get the sympathetic nervous system, which is fight, flight, or freeze. There's actually three kind of responses to that. And then you got the parasympathetic, which is rest, digest, recover, sleep. Right? We want to have a good harmony within those. We're not meant to be stressed chronically. There's a really good book called Why Zebras Don't Get Ulcers. And it sounds silly, right? But it's zebras, let's say the lion is chasing them. The zebra is either going to escape and go back to baseline, more parasympathetic, or it's going to get killed. It doesn't stay in this state where it's chronically stressed like we do. One night of modest sleep production will greatly increase your systolic blood pressure. One night. Some effects of undersleeping. And usually the stuff that I like to study, a lot of stuff that I've struggled with a lot. So I went for years with thinking I didn't need that much sleep because I was going to outwork everybody. I was going to sleep 5 hours a night, prove that I could do it. Right? My health went completely sideways. Growth hormone, okay, which replenishes the endothelium and does a lot of other things within the body as well, is greatly released while you're sleeping and while you're fasting. We're going to talk about that in a little bit, but sleep is where you're getting a big shot of that. chronic sleep deprivation is going to also significantly enhance your chance of becoming type 2 diabetic. So just sleep deprivation. Now, how much sleep are we talking about, really? Less than 6.5 hours per night. I bet you money that some of you in here are not sleeping 6.5 hours a night. Guarantee it. Thinking that that's enough. You don't need to sleep 9, 10 hours a night, but 7 to 8 is pretty much the sweet spot for people. 7 to 8. There are people like Richie who just went to use the bathroom. He doesn't need to sleep a lot. He's not setting an alarm clock. He just wakes up. There are people that have certain genes. There was an article, I think, in like 2007, The Sleepless Elite, and they were studying this mom and daughter. They would only need to sleep 2 hours a night. They were healthy. They were lean. Good attitudes. That's very rare, though. They do think people like Tesla and Benjamin Franklin might have had those genes as well, but most of us do not fit in that category. Another study, 200% more likely to have a heart attack or stroke if you're sleeping 6 hours or less a night. And part of the reason that this is happening, hormones, right, are replenished while we're sleeping, but the stress response. So getting into that sympathetic state where you're fight, flight, or freeze, if you're not sleeping enough, you're going to always be right at that cusp. So sleep, and if you've gotten a really good night's sleep before, which I'm sure we all have, notice how the worries you had when you went to sleep are pretty much gone in the morning. I don't think I had the study in here, but the one that really scared me with the sleep, when I started taking it more seriously, was the same one, 6.5 hours or less per night of sleep. I think it was like a 50% increase in your chance for developing cancer. It was crazy. 6.5 or less. So let's talk a little bit about nutrition. Sugar and animal meat both cause inflammation at the cellular level. Now, the root of every single disease is inflammation/insulin resistance. Every disease known to mankind. Those will be present with every disease. Both cause a major insulin response. So again, it's a big myth that if you eat protein, your insulin's not going to spike. So insulin is released, right, when it's got to clear glucose out of the blood. So this is where these concepts of keep your carbs low, keep certain types of carbs low is what it should say. Both lead to insulin resistance. So look at some of these, right? Replacing just 5% of the saturated fat in your diet with fructose, which is one of the main sugars within fruit. It's going to reduce your risk of developing diabetes by 30%. So fruit gets a bad rap. I used to be one of those people, again, coming from a bodybuilding background. It's got too much sugar. Can't eat fruit. Fruit, if you didn't know anything else to do with nutrition, just eat more fruit. Start with that. Half a serving a day of meat consumption, extra, almost brings up your risk of developing diabetes by 50%. So a half serving of meat, anybody know how much that is, a half serving?
3 ounces, 4 ounces?
It's basically at 2-3 ounces. It's not that much. It's not a lot. And there's plenty of studies that show that animal protein actually causes a disproportionately high compared to what the sugar's in it, right? There's really no sugar. It could convert to sugar. Insulin secretion. So this myth of, again, eat high protein as much as you want, keep carbs low, you're going to keep insulin low. It's not true. Sodium. Good book right here, The Salt Fix. All this doctor does is study sodium intake with his patients in different studies. There's, again, Andre could speak more to this at the end, and I've asked him about this stuff before. In some of these studies, they gave these patients up to 18,000 milligrams of sodium, which you cannot even do if you tried. Your palate wouldn't be able to take it. 18,000 milligrams. In a very, very small fraction of them, blood pressure went up a little bit. That's it. 18,000 milligrams. When you're chronically low in sodium, guess what happens to your heart rate? It goes up. Which he shows in the book is far more dangerous, you know, if other risk factors are accounted for, than a couple points higher on your blood pressure. You're making the heart work a lot harder if sodium is chronically too low. And for most people, they've been taught, keep sodium low, right? They've been taught, don't eat a lot of carbs, keep sodium low. If you have inadequate sodium, every cell in your body has what's called a sodium-potassium pump. That's the biggest part of your resting metabolism. The biggest energy expenditure are those pumps. So if sodium's low, those pumps are not going to work the way they should. Energy is going to be lower. Metabolism is going to be artificially suppressed because you're not giving the body what it needs. It's going to make you crave sugar and refined carbs. Most people, if they just increase sodium and made no other dietary changes, the body's going to start to change. They're going to start having less cravings. You can develop a good amount of insulin resistance by having low sodium. Your body needs sodium. Insulin, the hormone, what that does is it tells your body to store. It's an anabolic. It's the most anabolic hormone in the body. You probably heard of anabolic steroids. Just think of the word anabolic. It's growth. Most of the time, insulin is making us more fat. It's signaling us store, store, store. So if sodium's low, guess what insulin's going to do? The body's going to say, don't increase insulin because it needs to hold on to the sodium that it has. But if we're chronically getting insulin by eating the wrong way, low sodium, lack of sleep, we're going to become resistant to the effects. So now your body has to produce more insulin, more insulin, more insulin, to the point where they're going to put you on medication. Okay, they're going to put you on insulin, which makes the problem even worse. Sodium is actually very alkaline. So lack of sodium is going to make the body more acidic. When you get the sodium you need, sleep's going to improve. We talked about energy metabolism is going to improve. Mental focus, sexual performance, fitness performance. All these are going to improve. And these are validated through studies. It's all in this book I'm referencing right here. The average person should be getting about 3.5 to 5 grams a day. Most people are not there. Most people are 3 grams or less per day. If it's hot, like in the summer in New Jersey, and you're really working out hard, sweating a lot, go upwards of 8 grams a day. A lot of the professional sports teams now, they monitor this very closely with their athletes because they know how important it is for performance. So if you lost X amount of pounds of water in practice, you cannot leave until they give you these drinks with sodium. They'll put potassium in there too until you replenish that. So this is something that we recommend to our clients. So a lot of people that want to go on our different fasting programs, this is essential. This is essential. And what you do, basically, in 32 to 40 ounces of water, pink sea salt, low salt, which is pictured here. There's different brands as well. Potassium chloride, it's an easy way to get that in. And baking soda, which it's very good for your kidneys. It makes the body more alkaline. All right, and you just put 1/4 to 1/2 teaspoon in 32 to 40 ounces of water. Very easy to do. And again, if you didn't know anything else about nutrition, you could start with that, and it's going to help you a lot. You got it? Okay. Yeah. Okay, 4 key supplements to be taken right now. You're coming in, you got COVID going on, you're coming into cold and flu season. D3, there's over 3,000 different processes in the body that are all reliant on D3. Andre talked about vitamin D within his presentation. All detox genes within your body are dependent on D3. Right? Now, most people are going to, what I've learned from some really, what I would consider very brilliant functional medicine practitioners, the dosage people are going to recommend to you for D3 to get the number up is not even, the dosage that I've learned and that I've studied that they're going to give most people to take of certain things or where your blood work should be is basically for Homer Simpson. Picture Homer Simpson in your head. You guys don't want to just be this average couch potato. You want to have optimal health. Right? So the reason I'm telling you that with D3, taking 1,000 or 2,000 IUs of that a day is not going to and I've seen plenty of blood work throughout the years, is hardly going to bump your level up at all. It's better than not taking it. If you live basically above Atlanta, you're going to be deficient in your D3, okay, when you do your blood work. We mainly get it through sunlight, but when you wear sunglasses or put on sunscreen, it's blocking production. So this is one that you pretty much have to supplement. You could get it through egg yolks and stuff. Very hard to get that number up though. Glutathione, which we got glutathione right here. This is actually getting harder and harder to get. If you go on Amazon right now, they pretty much ban this because it's so effective. And what's it effective at is lung infections. So again, I study this stuff a lot because I'm prone to getting very bad lung infections. It's made in your liver. Okay, it's made in your liver. It basically will inhibit what's called like a cytokine response within your lungs. Right? And if you get one of these seasonal things, like I had the flu, I think it was 2 years ago now. It was the December before COVID hit. And I mean, that thing damn near killed me. Mike will tell, I lost like 35 pounds in like 2 weeks, but it got into my lungs. You know, I didn't realize until that point, I don't know if I've ever had the flu before. You know, then I started studying this stuff. So glutathione, zinc, very important. Okay, zinc's going to inhibit viral replication. But the problem is, and this is something I didn't know till this year, it's not fat soluble. It can't get into your cells. It's completely useless by itself. So you need basically a stagecoach or a transporter. Quercetin is a very simple thing that you can get, a supplement. Take that with your zinc. Again, zinc, when you're staying on that, is going to inhibit the replication of viruses, bacteria, stuff like that. Okay, so a couple more slides here. This is one of our clients in Hillsborough. Bill did a great job transforming his body. Doing what Mike said, show up, repeat, and he really took to the fasting, really took it to heart. You know, he really got on the fasting program. And when I'm talking about fasting, I think I have a couple more slides on that. You could go, the way I like to teach fasting is you jump right into it. Don't dilly-dally with it. Everybody's heard of like intermittent fasting. That's that's a form of fasting. Basically with fasting, eat less often. It takes 6 hours after you eat to enter a fasted state once again. So most people are hardly ever in a fasted state. The body is not designed to be constantly fed. It's not how the body functions best. Andre talked about eat more plant-based stuff. I'm not telling you to become vegetarian. Again, I love eating animal meat. But where all your micronutrients are going to come from is stuff that came from the ground. Majority of your micronutrients are coming from stuff that grew from the earth. Cool thing here, this is a liver cleanse that I take people through when they go through the fasting protocol. And if you, I think my email's on the last slide. I will email this to you if you want, the liver cleanse protocol. It's something, again, I didn't know until I started really studying this stuff. Andre talked about, right? Majority of your cholesterol is produced where? Everybody know? In the liver. Your liver is your main organ of detoxification. The liver, besides the brain, performs the most functions in the human body. Super important that you take care of your liver health. Super important. Now you can actually get, and I've gone through this about 3 times already myself now, you can get stones. I can almost guarantee everybody in here has stones within their liver. It's different than kidney stones. I'm not talking about kidney stones. I'm talking about stones that build up and clog the ducts within the liver. So this protocol, if you choose to do it, you will pass a lot of stones. You will see them come out in the toilet. You're not urinating them out. You crap them out. It's not painful at all. So day 1 to 6, just to give you a brief overview, you're just doing tart cherry juice. Try to get organic if you can. The malic acid is going to start softening those stones up. Looks more complex than it is, but when you get to day 6, that's the only day where you have to add certain things more than the cherry juice. You add that into your protocol. Okay? Day 7, is when you're going to start passing your stones. Again, it looks complex. It's not really complex. Is it strange? For most people, yes. It's a strange thing to do. Right? And you could do this basically every month until you don't pass any more stones. And the liver, right? The liver, I think Andre could speak more to this. You're getting a huge increase. I don't know if it's the past decade or whatever, but fatty liver disease in non-alcoholics. Okay, where your body stores toxins is within fat cells. So when your liver becomes fatty like that, it's a survival mechanism. Survival mechanism. Remember, your liver is your main, it's two things. It's your main fat-burning organ, and it's the main organ of detoxification. If you want to change your body and you want to have optimal health, start looking and taking your liver health seriously. It's not something most people think about. But you see, if you do like this liver cleanse or whatever, you can do it pretty easily, right? You can start focusing on this stuff. 4 keys to youth. So this is another really good dude that I've been able to learn from. Very interesting man. His name is Matt Fury. 4 keys to youth, right? Laughing. That's something you should almost keep a scoreboard of. Do you laugh every day at least once? Walking. Walking is the only form of exercise that's going to lower your stress hormones. I'm not talking about walking and going out and trying to get your heart rate. I'm just talking about walking. So in your brain, the same center, okay, where emotions come out of and pain, movement uses that same center. So you can rob that part of your brain if you have a stressful thing that's going on. You got a tough conversation. You got to go for a walk where you're having it if it's over the phone. Go for a walk with, when I do mind map sessions now, I don't do them very rarely. I did one the other night sitting down, but it's usually a walk now. I go for a walk with the person, right? It's going to dampen some of these harmful emotions that are coming to the surface. Okay, walking is very important. Squatting. I'm not talking about squatting with weight. I'm talking about if you went to any grocery store right now, picked out 20 people, I bet you maybe one of them can get down. Like when I talk about squat, I'm just talking about being able to use your joints and come down here. There's no weight on me, right? But if I can't do that, what is that doing for my freedom as far as freedom of movement and mobility? So the ability to squat. If you can squat, and it's something you can continue to work on throughout your life, you're going to be in pretty good shape if you can do that. And fasting. There's so many benefits to fasting. The weight loss is just the tip of the iceberg. Right? I've seen some crazy stuff the past 2 years, taking people through. So the program I'll take people through with fasting is more people that go through my program, they'll go right into a 48-hour fast. Right? It's a 6-week program. We do that. And then the rest of the week, they're doing 1 meal a day. So these people are going from maybe eating 16, 18, 25 times a week. Now they're eating 6 or 7 times a week, which sounds extreme. But and the reason we start with the 48 is because it builds their confidence and knocks out any fear they had around fasting. Besides sleep, fasting is the most powerful thing you can do for your health. And I love to eat. So you might think this doesn't fit your lifestyle if you really like food. It fits it more because the way we look at fasting, you're either fasting or you're feasting. When you eat, you're going to eat. Okay, and we teach people that way to eat. It's just so, I mean, you could do a whole seminar on fasting. Really good stuff though, okay? All right, before we go over questions, if anybody wants to do a free trial here, we don't have the forms. I'll just get your email at the end and we will email you. All right, and then you'll be with the coaches here. They'll make sure you're doing everything appropriately. All that, good stuff. And we do normally, when people do a trial with us, it's $200. So if you want to sign up for it, it will be free because you came to this seminar. No strings attached. Okay, so that is it. Does anybody have questions for Mike, Andre, or myself? Want to hit stop on that?